Hey guys, my name is Joe Rich. Today's video, I'm going to talk about the Time Up and Go, a functional mobility test also known as TUG. I will go over some of the different version of it as well. I will discuss the purpose, the age and population, equipments that needed. Also, I will show you how to administer it. I will have a demonstration videos and a psychometrics normative data. And lastly, I will have a discussion post. So what is TUG test? It was presented in 1991 as a basic test for functional mobility. It measures speed during several functional maneuvers, which include standing up, walking, turning, and sitting down. Now it's commonly used as a routine screening test for fall risk prevention in older adults, which was recommended by the American Geriatric Society. It's widely used in hospital setting, outpatient rehab, physical therapy clinic, nursing home, and home health, and other facility. The type of assessment is a performance-based measure. Age range is 60 and older. Population, it's commonly used in geriatric, like what I mentioned, Parkinson, MS, hip fracture, stroke, and other disability. Time administered, it's less than a minute. Equipment need, you'll need standard chair with or without armrest, measuring tape, piece of tape or a marker, and a stopwatch. It's simple to set up. You will first measure a 3 meter or about 10 feet walkway with a measuring tape. You'll place a piece of tape or cone as a marker. At the end of the walkway, you'll place the chair facing the walkway as a starting point. A quick rundown is that patient will wear their regular footwear and can use walking aid if needed. The clinician will explain and demonstrate. Patient will perform the TUG test and will be timed. They're allowed to do one trial test. So this is what the clinician will say to the client. When I say go, I want you to stand up from the chair, walk to the line on the floor at your normal pace, turn, walk back to the chair at your normal pace, and sit down. On the word go, begin timing and stop timing after the patient sit back down. Then you will record time. Also make sure that you are standing by just for safety. Here's the video demonstration. So make sure you explain and demonstrate to the client what we're gonna do. And make sure they understand it. So the client is allowed to have one practice trial, but if they refuse, they can begin right away in the time trial. So here it is. When I said go, she stood up. Make sure you are observing how she walked and how she turned, and you will press the time to stop. Here are the sample score sheet. One on the left is very basic. You use this in clinic setting most of the time. She scored 10 seconds. She didn't use any assistive device. She didn't stop or notice any impaired cognition. So she falls in the none to low moderate risk for fall. On the right side is the CDC version. It has a description and then the time where you're going to put her score and the date of the assessment. Also, there's some observation that you can check if you notice anything in there. So scoring this test is very easy. For older adults who takes 12 seconds or more, they are at risk for falling. 10 seconds or less, they are normal. 20 seconds or less, they're good mobility. They can go out alone. They're mobile without assistive device. 30 seconds or less, there's some problem. They cannot go outside alone, requires assistive device. Overall, if they score 14 seconds or more, it has been shown to indicate high risk of fall. Important note, and make sure that if the patient requires physical assistance to stand or walk, this test is not recommended. Cutoff time for high risk for fall in different population is listed right here. For psychometrics, here are some examples of normative data in the geriatric rehabilitation and in the community dwelling elderly people. Reliability for this test is pretty good. It scored high in elderly population. In the community dwelling population, it scored moderate. And the population in Alzheimer's is pretty high. And population in patient with Parkinson, it's also high. Psychometric continue in the minimal detectable change. I found that in Alzheimer's patient there's 4.09, in chronic stroke it's 2.9, and with Parkinson patient is 3.5. In the minimal clinical importance difference, there are 3 established methods that were used in anchor-based MCID, and pretty much what it means is that it's valid and it's a stable measure. So right now I'm gonna move on and talk about the different variation or version of the TUG test. There are 3 that are very common. The first one is the modified TUG. The second one is the TUG cognitive, and lastly is the TUG manual or motor. So I'm gonna talk about the modified TUG first. I found 2 versions of it, so I'm pretty sure there's different kind, but this one is the one that I found. They incorporate split times to break the TUG into subsection, such as sit to stand, and then they will time that, and then stand to walking, walk, turn, walk back, turn, and sit. So they pretty much time those different, and then they will just add them together. The second one that I found is that there were assistants, which is pretty interesting. So the tester will give a hand-to-hand assistance while the client walk. However, if they cannot complete it, the client will receive a full and they will fall in the high-risk category. Here's one quick demonstration of one of the version of the modified TUG where I assist the client as she walks. So the TUG cognitive, it's the same setup, but with secondary cognitive tests such as counting backward by 3s from random selected numbers between 20 to 100 or reciting alternating alphabet letter. It's good for patients with cognitive impairment due to high focus and cognitive attention to their balance. Here's the quick demonstration. The client successfully completed the test without any issue. So the last test that I'm going to talk about is the TUG manual or the motor. It's the same test but with the secondary activity testing motor control, such as walking while holding a cup filled with water. Here is the demonstration. The scoring will be the same, but it will be dependent on the population, as you can see right here. For psychometrics, here are some examples of normative data in Parkinson's disease and the community dwelling elderly. The reliability for this different version show excellent in the community dwelling adult ages 60 to 70 and with Parkinson's disease. Validity was also excellent, correlate in the Berg balance, but low to none in mini-mental and clock tests. The MDC and MCID was also valid and measurable. Finally, here are some questions that I have for you guys and my reference. Thanks for watching.